Hello, I'm Dr. Ken Landau. Thanks for watching. Let's discuss the concept of taking a low dose of aspirin to prevent heart disease. Well, we're going to limit our discussion to primary prevention of heart disease. So in people who are otherwise healthy, at least from a cardiovascular standpoint, they have not had a stroke, they have not had a heart attack or any evidence. They might have high blood pressure, they might have high cholesterol, they might be diabetic, but they haven't had a heart attack, they haven't had a stroke. That's primary prevention. And we have to decide if aspirin is a good idea for those individuals. Now, secondary prevention is preventing a recurrent heart attack or stroke. People who've already had a heart attack or stroke, those people seem to be likely to benefit from aspirin. We're not talking about them. We're talking about primary prevention, two completely different scenarios. And here in America, it seems that we are a nation of pill takers. So about 40% of the people who are at very low risk for heart disease, who've never had a heart attack, they take aspirin already. People who are at very high risk often misjudge their risk. They think they're at low risk. Well, as far as taking aspirin to prevent the appearance of your first heart attack or stroke, it's highly controversial. You hear so many people talk about it as if it's a given, but it is not. The benefits are far from certain as far as primary prevention is concerned. It only works for certain people to decrease the risk, and certainly those people who are at highest risk seem to benefit the most. Now, at the present time, there is evidence that aspirin might decrease the incidence of coronary vascular death, of fatal and non-fatal heart attack, of fatal and non-fatal stroke in those people who are at sufficient risk. Interestingly, low-dose aspirin in people who are between the ages of 50 and 59 might also reduce the development of colon cancer, and low-dose aspirin might reduce the incidence of pre-eclampsia. That's a complication of pregnancy. Now, the story of aspirin goes back a long time, goes back over 2,000 years. In 400 BC, Hippocrates was able to get the bark of the willow tree and identify it as having some beneficial effects. Salicin, the active component, was identified in 1829. In 1853, a physician named Gebhardt actually was able to neutralize the salicin by adding some acetyl chloride and some sodium. That's why it's called acetyl salicylic acid. And he didn't do anything further with the substance, didn't market it. But in 1897, Hoffman, working for Bayer Company in Germany, he rediscovered the original formula. He named it aspirin. And the aspirin, interestingly, the A stands for the acetyl chloride. The spire, S-P-I-R, stands for Spirulina omeria. That was the plant that the material came from. And the in was just a very common ending for drugs in Europe in the late 1800s, early 1900s. This subsequently became the best-selling drug of all time, probably couldn't pass the FDA at the present time. So low-dose aspirin, in the unmodified terms, means less than 325 milligrams. There's no specific evidence that suggests any dose below that point beats any other dose below that point. We call very low dose aspirin less than 100 milligrams a day. Low dose is less than 325 milligrams a day, and the regular dose is more than 325 milligrams a day. Typically, if you have a headache or something, then you would take aspirin at a dose of 650 milligrams several times a day. Now, the reason that aspirin works, at least as far as the low dose is concerned, is it inactivates the platelets. And the platelets are the substances in the blood that lead to clotting. The aspirin works on these platelets, completely inactivates them at a dose of 20 or 30 milligrams. So you don't really need very much. But by international guidelines, there's a buffer zone that we set up, or that has been set up. So the recommendation is to take 3 to 10 times more than the active dose in order to accommodate for different body weight, different rates of platelet turnover, different amounts of drug absorption. And as a result, now we take what we here in the United States consider low-dose aspirin, 81 milligrams a day. Prevents platelet clumping. It works on those platelets, those little fractions of cells that float around inside the blood. It works to prevent an enzyme known as COX-1 from working. COX-1 is important because it's necessary to make a change in a chemical known as arachidonic acid and make it into a substance that constricts the vessels known as thromboxane. So no COX-1, no thromboxane. That's good if we're talking about the clotting purposes. Now, aspirin seems to work much better to prevent arterial clots than it does to prevent venous clots. So aspirin isn't really a good drug if you're trying to prevent, say, deep vein thrombosis or pulmonary emboli. If you want to prevent vein thromboses, then you need a drug like warfarin or Eliquis or one of those kind of medicines. Aspirin doesn't seem to work very well. Aspirin is a type of non-steroidal anti-inflammatory drug. You hear so much talk about NSAIDs. Well, aspirin is an NSAID. Aspirin, however, permanently inhibits that enzyme called COX within the platelet. On the other hand, we have to be a little concerned because the platelets are constantly being manufactured. So the life of a platelet is about 8 to 9, maybe to 10 days. So there's a constant turnover. So if you take aspirin now, it's going to inactivate the platelets, probably prevent the clotting for a period of about 96 hours. On the other hand, if you take any other of the non-steroidal anti-inflammatory drugs, maybe ibuprofen, maybe naproxen, they're reversible. They're only going to work for a couple of hours. Now, the whole scenario starts when you develop a little atherosclerosis, little hardening of the artery. You get some fatty substance, and then you get some cell waste, then you might get some calcification or some other substances that take place, and you have a fragile area of atherosclerotic plaque in the vessel that could break down. And when it breaks down, it initiates the clotting activity. The platelets clump at the site, and then they could block the vessel. And when it blocks the vessel, that's when you have the heart attack or the stroke. So low-dose aspirin is going to favorably alter the ratio of thromboxane to another chemical that the vessel walls make to protect themselves called prostacyclin. Now, if you take aspirin, it's going to be absorbed in about 30 to 40 minutes. It's going to be systemically available, about half of it, but less so if you take an enteric-coated aspirin, or if you take a sustained-release aspirin, or if you take a microencapsulated aspirin. Half-life of aspirin is very short. It's only going to be about 15 to 20 minutes. What happens is you take the aspirin, goes to the stomach and the intestine, is absorbed, goes into what we know as the portal circulation, the circulation that goes to the liver from the gut. It inactivates the platelets, and then when the aspirin reaches the liver, it's very quickly inactivated. So the antiplatelet dose, 75 milligrams to 325 milligrams, no additional benefit if you happen to take more. Low-dose aspirin, well, it might prevent the heart attacks in people at risk. There's less evidence to suggest that it's going to be able to decrease the incidence of stroke. Experts disagree which high-risk patients should actually be considered candidates for taking the aspirin. It seems that most experts agree that if your likelihood of having a cardiovascular event, a heart attack or a stroke, is greater than 10% over a 10-year time period, then you could consider taking low-dose aspirin. That would be an option. If your risk is less than 10% over 10 years, probably not a great idea. Now, low-dose aspirin, 75 milligrams, 325 milligrams, not standard. In the United Kingdom, they take 75 milligrams. That's their standard low-dose aspirin. Here in the United States, it's 81 milligrams. Doesn't seem to make any difference. Typical range in various countries, anywhere between 75 milligrams and 162 milligrams, but don't take the coated aspirin. Coated aspirin doesn't seem to have the same kind of benefits. So, what is the likelihood of your being able to reduce your risk if you take low-dose aspirin for primary prevention? Well, the answer is that it seems to reduce the likelihood of serious cardiovascular events by about 12%. And if we look at the decrease in the non-fatal heart attacks, it's about 20%. Non-fatal strokes, it's only about 5%. That's not statistically significant from taking a placebo. And if we look at fatal strokes, there's no information whether it can prevent fatal strokes. Cardiovascular disease, the death from cardiovascular disease, no evidence that it does that. All-cause mortality, does it decrease it? No evidence that it does that. But let's go back to this 12% reduction in the risk of cardiovascular events. That sounds like it's a lot, but it all depends where we start. So the risk that the people had who were taking the aspirin in the first place, before they took the aspirin, their risk of having a cardiovascular event was 0.57% a year. And the 12% reduction reduced it to about 0.51% per year. So in other words, taking aspirin, that everybody seems to think is such a great product, actually reduced the risk of a cardiovascular event by 0.06%. That doesn't sound so impressive, does it? And the risk of reducing the likelihood that you're going to have a non-fatal heart attack, it's reduced by 20%. But again, let's see where we start. We start at a risk of 0.29%. That's the risk of a person having a heart attack otherwise in the course of a year. And that risk is reduced by 20% down to 0.18% per year. So that fancy 20% relative reduction actually is less than or just about 0.1%. So that's not very impressive at all. So how do we decide what the real risk is? Where do you fit in? Are you a good candidate for aspirin or not? Well, we go to a risk calculator. And you can go to the American College of Cardiology, acc.org, American Heart Association, AHA.org. You can go to either of those sites and a bunch of others, and you can find risk calculators. And the risk calculators are basically meant for people between the ages of 40 and 79. There's not great evidence that they work in people over age 80. And you have to realize the risk in women sort of lags by about 10 years behind the risk for men. The risks that are used to calculate on the computer are called pooled cohort equations. And these look at the risk of non-fatal and fatal heart attacks and stroke and and cardiovascular death. And what they actually do is they seem to over-present the risk. They over-predict the risk. They were done in several cohort studies, and those aren't the kind of risks that our population now faces, so it's thought that they over-predict the likelihood that you're going to have a heart attack or a stroke. Well, there are several other risk calculators. You don't have to have the American College of Cardiology or American Heart Association. There are others, but they're not as widely accepted. They're called SCORE or the Framingham or the Assign from Scotland or the Q-Risk or the ProCam or the Globo Risk. They don't evaluate certain factors that actually do increase the risk. So a person who has pre-eclampsia has a higher risk. A person who has pregnancy-induced high blood pressure, higher risk than the tables would calculate if you have polycystic ovary disease, or if you have gestational diabetes, HIV. or if you're suffering from rheumatoid arthritis, certain other kind of inflammatory diseases, your risk is higher than the calculator is going to tell you. But the baseline is, if it's greater than a 10% risk of a heart attack, risk of a stroke over a 10-year time period, then you're a candidate for primary prevention. The information you need to input into the calculator to find out your particular risk, you have to put in your age and your sex and your race and your systolic blood pressure. They want to know what your cholesterol is, so it has to be measured, your HDL, or your good cholesterol, and then whether you have a history of diabetes, high blood pressure, whether you're a cigarette smoker, and whether you take aspirin or a statin. Well, now it becomes a point where we have to look at the risk versus the benefit. So we've already said that when we're looking at the absolute benefit could be 0.06% per year in people with a 10% 10-year risk. On the other hand, the risk of aspirin doing you harm is about 0.03%. So in other words, the number of people we would have to treat to get some kind of benefit to decrease the likelihood of a cardiovascular event over a 6-year time period, we would have to treat 120 people every single day. And to decrease the risk of a non-fatal heart attack, we would have to treat, over that 6-year time period, 162 people to benefit one individual. On the other hand, the number of people we would have to treat over a 6-year period to increase the risk of significant bleeding is only 73. Another analysis, using other figures, looked at the number necessary to get a benefit to reduce the incidence of major cardiovascular disease. We would have to treat 284 people, on the other hand, to harm one individual. We would treat 299 people. So basically the same risk as benefit. Now, the risk to aspirin seems to be bleeding. And it seems a lot to have to do with gastrointestinal bleeding. So if you have a history of gastrointestinal bleeding, upper gastrointestinal pain, if you've been taking aspirin for a long time or at a high dose, or you have something wrong with your kidneys or severe liver disease, or you have a decrease in your platelet count, or you have a bleeding disorder, you have diabetes, you're taking another non-steroidal anti-inflammatory, you're taking some ibuprofen or naproxen for your joint pain, or if you're older, or if you're a cigarette smoker, or if you have high blood pressure, or if you have more than 3 alcohol-containing drinks a day, then you're more likely to have some bleeding. Well, let's look at some practical consequences. Let's look at some numbers. So let's take 1,000 people. And let's say the risk is 10% over 10 years. So in other words, 1% in 1 year. Well, if we take 1,000 people and they have the 10% 10-year risk, that means over the course of a given year, in 1,000 people, 10 individuals are going to suffer some cardiovascular event. And if aspirin is able to generously reduce the risk by, let's say, 25%, that means that if we started with 1,000 people, 10 of those individuals are going to have an event. We're going to reduce the risk by 25%. So we're going to reduce the risk in 2 to 3 people. So 2 to 3 people are not going to have a cardiovascular event in that 1,000 individual population. On the other hand, it means that aspirin won't work in 75% of the people. So that means that 7 or 8% of the people, even though they're taking aspirin, still going to have a heart attack or a stroke. And if we take people who are at higher risk, let's say 40 to 80% over a period of 10 years, that's 4 to 8% a year. Well, if we start off with 1,000 people, we're going to find that there are going to be between 40 and 80 events in this very high-risk group of people, and we're still going to reduce the risk by about 25%. So in other words, we're going to prevent 10 or 20 individuals out of 1,000 from having a heart attack or a stroke. But that means we are not going to prevent 30 or 60 of the people from having a heart attack or a stroke. And remember, we have a significant increase in the incidence of major gastrointestinal bleeding that would lead to either a transfusion or hospitalization or death. And by the way, if you're taking aspirin, it's not a good idea at the same time to be taking warfarin or Pradaxa or Xarelto or Eliquis, have a bleeding disorder, uncontrolled high blood pressure, severe liver or kidney disease or asthma, taking those other non-steroidals. They don't mix. So for those people, probably not a good idea to start or to be taking the low-dose aspirin. Other kind of problems taking aspirin, it can upset your stomach, lead to heartburn, nausea, vomiting. Less commonly, but certainly still in the realm of possibility, it can cause liver disease, kidney disease, and certain neurologic dysfunction. Now, aspirin performs the same risk reduction irrespective of where you start. It's still about 20 to 25% risk reduction. The people who seem to be at higher risk, those people are the ones who seem to benefit the most. Now, the reason that a substantial number of people continue to have cardiovascular events even though they're taking aspirin and even though the aspirin has inactivated that COX enzyme that leads to the platelet clumping together, well, there are many different ways that we can activate the platelets, ways other than through this COX pathway. And that's why it's so controversial, because it doesn't work for everyone, and a significant percentage of people who think they're at risk are really getting minimal benefit, but increasing their risk when they take aspirin. So what's the recommendation? The recommendation of the widely respected United States Preventive Services Task Force, this is basically the government recommendation, is if you happen to be between 50 and 59, there is a grade B recommendation. In other words, the best recommendation would be a grade A recommendation. A recommendations, we have good evidence supporting. This is only a B recommendation. That's a high certainty that it's going to give some people some moderate benefit, or moderate certainty that some people are going to get substantial benefit. So if your risk of having a heart attack or a stroke in people who have not yet had one is at least 10% over 10 years, and you don't have any other problems that we talked about that would increase your risk of bleeding, and your life expectancy is at least 10 years, and you're willing to take aspirin every single day for at least 10 years, then you might receive some kind of benefit. And by the way, they just threw in 2016 for the first time, it might reduce your risk of colon cancer. Well, now let's say you're between the ages of 60 and 69. It's only a grade C recommendation. So there isn't as much evidence, and the evidence is kind of equivocal, to support people between the ages of 60 and 69 taking aspirin. And as far as the chance of reducing the likelihood of colon cancer, now the evidence isn't nearly as good either. And as a matter of fact, there's no data to suggest that aspirin is going to be beneficial for the average person if they're less than age 50 or if they're greater than age 70. Well, while the recommendation is that if your risk is 10% at 10 years, you should consider taking aspirin, some people say, no, let's bump it up to, say, 15%. And a lot of people say, well, let's consider 20% risk over a 10-year time period. So there's a gray zone between 10 and 20%. What are recommendations of some other people? We talked about the United States Preventive Services Task Force. The American College of Chest Physicians says, hey, you're over age 50, you got a little risk, we're going to recommend it, but with some reservations. The American Academy of Family Practice, they say exactly the same thing as the United States Task Force. American Cancer Society doesn't take any stand. The European Society of Cardiology, they recommend against taking aspirin in healthy individuals. The Joint British Society of Cardiovascular Disease, they recommend against aspirin in healthy individuals. The American Heart Association only recommends aspirin for people who are at significant risk, But they say, don't take it by yourself. Start by talking with your doctor and determining whether you're likely to get any benefit. The National Institute for Health and Care Excellence in the United Kingdom and Britain, they don't recommend aspirin even if you're diabetic. The Irish Heart Society, well, they say aspirin for primary prevention is not advised. Maybe if your risk is sufficiently high, it might be considered, but certainly not for the general population. The American Diabetic Association says, well, consider it if you have a risk of more than 10% over 10 years, but certainly not in women who are less than age 60 and men who are less than age 50 if the risk isn't substantial enough. Well, adding a little fuel to the controversy, at a presentation at the American College of Cardiology in February of 2018, looking at the medical records, what we call retrospective review, of 12,000 people who were over 55, who were followed for 5 years. These people had type 2 diabetes, congestive heart failure, so they were at very significantly increased risk. What did aspirin do for them on a regular basis? Well, it seemed to reduce the chance of death and hospitalization from heart failure by about 10%, but taking the aspirin seemed to increase the risk of non-fatal heart attacks and increase the risk of non-fatal stroke by about 50%. Now, heart disease is very expensive and it's very devastating. We spend about $350 billion in the United States each year to take care of heart disease and its consequences and other cardiovascular diseases. That's more than 9% of all of the money that's spent for cardiovascular or for medical purposes. Now, it's important to realize that modifiable risk factors, things that you can do yourself through lifestyle and behavioral changes, can potentially prevent 80% of all cardiovascular disease and as much as 40% of all cancer. Now, heart disease causes 30% of all deaths in the United States. Deaths from heart attack, deaths from stroke. And the current rate of heart disease has fallen by over 50% from what it was in the 1980s. That's principally because there aren't as many smokers and we're controlling the blood pressure. But unfortunately, counteracting those changes, we're getting fatter, there's more diabetes, more type 2 diabetes, and the population is growing older. And even among people who are at significant risk, at least 50% are not following at least one guideline to reduce their risk. They're still smoking, they're still eating poorly, they're still not exercising, all of those bad kind of activities. So if we pay attention to our diet, if we pay attention to exercise, if we pay attention to a variety of changes, including cutting down on the amount of salt in the diet, cutting down your salty foods, cutting down the pizzas and burgers and chicken nuggets, and all of those sorts of things, then it seems that aspirin becomes moot because aspirin isn't nearly as potent as those factors. So if you really want to reduce the risk, it isn't a question of taking aspirin for primary prevention. What it's a situation, what the major problem is, changing your lifestyle, changing your behavior. If you can successfully do that, your blood pressure is going to go down, you're going to have less cardiovascular disease, less likelihood of developing atherosclerosis, reversal of some atherosclerosis, and if you follow a prudent lifestyle, you're going to reduce your risk of cancer as well. That's where we should put our efforts. Low-dose aspirin for primary prevention, actually the numbers are pretty unimpressive. Anyway, thanks for watching. I'm Dr. Ken Landau.